Assalamu alaikum. Good afternoon, everyone. So basically, I'm going to talk about the refractive enhancement after corneal refractive surgery. Just we cover the corneal part. Waiting for the slide. Is this working now? It's not working, this one. Okay, so basically it's just, as you know, refractive surgery, cornea, phakic or refractive lens exchange, but I'm concentrating people who had the corneal refractive surgery. First of all, when you had the patient coming for refractive enhancement, you need to know what's happening and what's exactly. So refraction is very important. You need to do refraction. Some cases you need to consider cyclovision refraction to make sure that you had the right correction refractive before the treatment. You need to check the quality of the vision, if the patient is happy with the vision. Dominant eye, consider if someone had presbyopic age, consider maybe you not need to treat both eyes. You may need to consider monovision, and very important to have stable refraction. Always you need to consider corneal topography. Epithelium mapping nowadays, I do it for everyone, but really for enhancement, it's very crucial to have epithelium mapping if you have, and you consider CT. And also that will help you also to check if someone had LASIK surgery, at least you know to know what's the thickness of the flap. Regarding why people had not a good result after refractive laser surgery in cornea, it could be straight away after surgery, could undercorrected, overcorrected, or the effect of the flap. By the way, I have 10 minutes, not 7, okay? Regression, it could be people epithelium thickening or stromal thickening, or very important to exclude ectasia, because ectasia, if someone had refractive error remaining after laser surgery, you make sure that's not ectasia and you treat it and you're creating even worse. Epithelium mapping is very crucial, as mentioned, because if someone had thicker epithelium, it will affect you what you're going to do. If you remove the epithelium and the patient become the epithelium different thickness, it will give you unpredictable result. If you use a trans-BRK, if you know the epithelium, you could still use trans-BRK as an option because you know the epithelium exactly how it's the thickness. Without it, you have to remove the epithelium. So epithelium modeling, it helps us in one way, but harm us in other way if we don't know how much that regression. Regarding the epithelium role, which people talking about it, it will help us to exclude ectasia, help us predictability. One thing is for hyperopia. If someone had thin epithelium, if you corrected more hyperopia, that become they call apical syndrome, where they become very dry in that epic, and that's really it's very important to have epithelium map for hyperopic enhancement. And as I mentioned, will help us to decide is it PRK or trans-BRK. So the option, you lift the flap. So that's one option after LASIK. The second option, you could do trans-BRK or BRK over the flap. The third option, you could be creating another flap edge. With the femto laser, you can do another flap edge with the femto laser. Or some very rare, I've done a few cases before where I lift the flap, the thickness wasn't good. So I have to do the treatment in the back of the flap. That's for very selective cases only. Or you could be creating another flap LASIK with the femto if you had the first flap very thick, which is very few cases. Another option, you could consider phakic implant, intercorneal ring, a flex, or a relax. Regarding the treatment profile, usually we do it if the patient happy with the vision, we do standard refractive error correction. But you may need to consider wavefront or topo-guided if the patient had not good quality of vision, and that maybe had night vision problem, a previous small optic treatment before, the central ablation. But remember that when you play with topo-guided or wavefront guided, you may overcorrect the patient, so you need to check and look to the number what you're going to correct. The complication when you lift the flap, always we concern about epithelium growth, ectasia, DLK, corneal abrasion, stria, flap tear, flap melt or infection. Regarding the epithelium growth, always that's the commonest risk factor. And really there's very relationship. If someone had the flap for a long time, you had the risk of epithelium growth high. Microkeratome tends to have risk of epithelium even more than the femto laser because of the design. Hyperopic treatment primary because when you treat hyperopia, you damage the edge of the flap, so your risk of epithelium growth even more. But really, I think the most important factor for flap lift is really the surgical experience, how you handle this flap. So if you lift the flap very careful and gentle, you have much less risk of epithelium growth. There's one study showed that the risk of epithelium growth, if you do it with the first 3 years, it's like 1%, but after 3 years, it become much higher, about 7%. Regarding the other option, as we say, BRK over the flap. The risk we worry about This option is the corneal haze, the pain, slow recurrent corneal erosion, DLK infection. But the more important, really, the predictability of the result, because the epithelium it heal different. So by doing a BRK over the flap, your predictability is slightly less than what you want. Regarding the use of mitomycin C, it's a long time. There's a study by Corona. They did BRK without mitomycin C. Majority of the patient had very bad haze. But when he used the mitomycin C, that the haze dropped significantly. So nowadays we use mitomycin C for anyone. You do enhancement over the flap. So, and that's the duration, as we say, there's too many different factors to use, but it's very important to use mitomycin C. Regarding the option advantage of BRK over the flap, really when you do a BRK over the flap, there's no problem with epithelium growth. You don't weaken the cornea because the flap doesn't have any strength, so you don't weaken the cornea. If there's any fine wrinkle, you could also improve that by doing trans-BRK or BTK over the flap. You could improve the wrinkle, and we could treat recurrent corneal erosion if someone had it. The enhancement of post-BRK, usually if someone had BRK, usually we do BRK another one, okay? Unless very selective cases, you may consider to do femtolasic flap. If someone had very regular epithelium, you worry about remodeling and the risk of corneal haze. If someone hyperobic treatment, so patient had BRK and hyperobia now, so I'm not worried about haze, I may do femtolasic. And if someone had very bad experience with BRK but because of pain, I may do LASIK flap if he's a good candidate for the LASIK flap. Regarding the lenticular smile or clicks, usually it's always for enhancement for this patient. It's always the most common, us we do BRK. It's the safest and the most common method. Usually there's slight risk of haze. You could consider femtolasic flap, but you need to have the original cap of the flex should be thicker, or you do this circle or phakic implant. I will be short of time. I'm going to pass this one because they haven't given me all the money. So basically, if a patient had a LASIK flap, so if you had the first, by the way, I have 2 minutes, but anyway, for LASIK flap, if you had the LASIK flap, usually most of us, we lift the flap because that will give better vision result, better quality vision, but you need to be very careful about flap lift. As mentioned, for BRK, we do another BRK, most of us, and for the smile, we usually do BRK, and I don't do another flap. Thank you very much. But I had 10 minutes, by the way, my talk, and you give me 7, okay?
Thank you very much, Dr. Osama. You are very generous, actually.